So we're going to talk today about hip and knee arthritis, how you get it, what it is, and I guess what to do about it. Okay, so this is a big problem. 40 million Americans, all these statistics sort of, I don't know, sometimes they stop meaning things because they're just such big numbers. There's two types of arthritis, two big types of arthritis. So-called osteoarthritis, which is the wear and tear arthritis that the vast majority of people with arthritis get. It tends to be more common as we get older. It is perhaps related to activity, but it's not quite that simple. If osteoarthritis came from running, we'd expect it to find it in our marathon runners when they get to be 70. Well, we don't. If osteoarthritis came from standing on concrete all day, we'd find it in our manual laborers, and we wouldn't find it in people that had sit-down office work. Well, that's not necessarily true. So yes, it is wear and tear arthritis, but it is not just about the activity that you have or haven't had through your life. It's more complicated than that. There is definitely a genetic component. Now, there's a second type of arthritis as well that we're not going to touch on too much today, although the surgical treatment is essentially the same, and that's inflammatory arthritis. Now, the prototype for inflammatory arthritis is something like rheumatoid arthritis. Rheumatoid disease isn't about wear and tear, it's about the body's immune system somehow seeing the surface of the joint as an enemy and attacking it and trying to destroy it. Rheumatoid arthritis is seen in young people as well as old people. It isn't activity related. There is a genetic component to that as well. So we're going to mostly talk about osteoarthritis. It's more common. Knee replacement, I think I go over this a little bit more in a bit, but knee replacement is now the third most common operation done in the United States, and it's the most common operation done at the Billings Clinic in the primary operating room. Over at the surgery center, we do more cataracts and we do joint replacements, but not by very much. So this is a very common problem. It's the most common surgery done at the Billings Clinic Hospital last year. Okay, it affects all races equally, more women than men after age 50. And I think as we touched on before, most of us will have some degree of arthritis by the time we get into our 60s and 70s. There is a national number right there. It's actually higher than that, more like 700,000 or 800,000 projected by this year. There's so many knee replacements done. But I read a couple years ago that by 2025, because of aging population and our extended lifespans, that every orthopedist in the United States will need to do about 120 knee replacements a year in order to fulfill the demand. And that's not that far away, and most orthopedists don't do this, not that it's overcomplicated. There's lots of subspecialties within orthopedics. And you can be a spine surgeon, you don't do knee replacements. You're a pediatric orthopedist, you don't do knee replacements. You're a sports medicine guy, often they don't do knee replacements. So there's a big burden here of trying to get all this taken care of, and it's very common. Okay, osteoarthritis. Again, wear and tear arthritis, where does it happen? Knees. We do knee and hip replacements, are our two most common joint replacements. We do almost 2 knees for every hip. And then the third most common is shoulders, and we do probably 8 knees for every shoulder, maybe even 10 knees for every shoulder. There are now ankle replacements. Very unusual. Maybe we did 6 or maybe 10 last year. Our ankle replacement person's no longer with us, so we're not doing that operation. Although there is a orthopedist up the street doing that. So those are our big ones. Knees, hips, shoulders, ankles. There are such things as elbow replacements as well. A very subspecialized group of people would that be appropriate for. Okay, so what is a joint? So we're going to go through what is arthritis, how do you get it, and just a little bit about that kind of stuff. So this is a diagram of a joint. We have a bone, and the joint is where they come together, and they are coated with a surface called the articular cartilage. You can think of it as tread on a tire, or icing on a cake, if you will. What arthritis is, and this is true of whether we're talking about osteo or wear and tear arthritis, or the less common inflammatory rheumatoid type arthritis, what arthritis is a wearing away of the surface of the joint. So that smooth, glistening surface slowly wears away, and then that exposes the underlying bone. And the bone isn't meant to be a surface of the joint. It is rough, and it's hard, and it just doesn't allow for friction-free motion, and that hurts. Now, the interesting thing is, why does it hurt? Because there are no nerve endings inside bone. I can take a pin in the emergency room, and if I numb up your skin and your muscle, I can drive a pin right through the middle of the bone. I used to do that all the time when I was in training to treat kids with femur fractures. We'd hang them in traction. You can put these pins in the emergency room. It doesn't hurt them because there's no nerve endings in the bone. So it's something about the inflammatory or the irritative effect of this cartilage being worn away that causes pain, because the bone itself doesn't hurt. I think we'll refer to this a little bit later, so I'm going to go through it. The lining of all joints has a specialized cell in it called the synovial membrane. These are the cells that secrete the fluid, the oil, that lubricate the joint. And they are naturally replicate. When you remove synovium, it sort of comes back again. So we don't have to worry about removing too much of this lining because it'll regenerate itself. One of the important things to know about arthritis and the way joints work is that when we break a bone, the bone will form new bone and it heals. When we crack cartilage, or if there's a defect or a wearing away of the cartilage, the body does not regenerate the surface of the joint. Unlike skin regrows, that's scar tissue. Unlike bones that are broken, they regrow and the bone heals. We don't do a very good job, the body doesn't do a very good job of replacing worn out cartilage. All right, so here we are. This is again, schematic, diagrammatic here, that same illustration again with the surface of the joint. Here is what arthritis is, wearing away of the tread or disappearing of the icing, however you want to think of that, exposing the underlying bone. These are diagrams of the same thing, femur up top, tibia down below. This, by the way, is the ACL that you hear all the time. There are two shock absorbers inside the knee as well. They can be affected by arthritis, but the primary problem isn't the ligament issue, isn't the cartilage or the meniscus issue. It's the surface of the joint gets damaged. Here's an actual picture. This is an arthroscopic picture. That is the end of the thigh bone right there. So this is the tread on the end of the femur. This is the tread on the top of the tibia. That is that little shock absorber or the meniscus. That's normal. That's what it should look like. Here is an actual picture of an arthritic knee. Again, the cartilage or surface of the joint up there. You can see it's got grass sort of. This is how it degenerates. It looks like the lawn needs to be mowed. And eventually it all wears away, exposing the underlying bone, which is yellow when you look at it. And then this is the synovium, or that tissue that lines the knee. It gets all inflamed, and that's why this arthritis hurts. That really doesn't hurt, but this does. All right, so here's the picture of a ball of the hip. Again, the same sort of thing. This is a little bit of synovium on the sides. That's pretty decent looking tissue on the ball of the hip. And then here are actual pictures of an arthritic hip that's degenerative and the surface is sort of ripping up in there. Okay, so primary osteoarthritis, as I said before, is the most common. It is increasingly seen as we get older. The surface of the joint, that cartilage changes, the properties of that cartilage changes, the water content decreases, and it just becomes prone to wear and tear. It is not absolutely the result of aging, and while most of us have some arthritis in our 60s and 70s, there are some people who reach their 80s and 90s and have very little. Again, the cartilage does not repair itself very well, and what little ability it does have decreases with age. Ligaments are the ropes that hold joints together, and they weaken with age as well, and we can get some instability in these osteoarthritic joints. Okay, what causes it? We said the age itself is an automatic cause. It's not. Obesity is associated with especially knee arthritis. One of the reasons we're doing so many knee replacements is we are getting bigger as a society. Obesity both causes or is associated with arthritis of the knee, and it also makes it hurt more because extra weight transfers more force across these diseased joints. One of the treatments for arthritis in the setting of obesity is weight loss. Doesn't make the arthritis go away, but it doesn't hurt as much because you're not transferring as much forces across it. Old joint injury definitely can predispose to arthritis in the here and now. Can't tell you how many times I played football when I was in high school, and man, I blew this knee up, and back then you didn't go to a doctor, and so we didn't do anything about it, and it's always been a bit of a trick knee, and now here I am at 58, my knee's all worn out, get an x-ray, and sure enough. That knee would have been just fine without the injury that he had when he was 16, but a lifetime of an unstable joint can definitely lead to arthritis. Fractures that need to be treated surgically right around joints can lead to arthritis later on. Gout can cause arthritis. Less common, but it can. Gout is actually an example of inflammatory arthritis. We talked about rheumatoid being the prototype, but gout can cause that even though I've got it under osteoarthritis here. And then abnormal joints. Okay, so we talked a little bit about weight loss, and for each pound of weight loss, there's a 4-pound reduction in the forces hitting the knee just while walking. That's not running, that's with walking. So as we walk, we call that a joint reaction force. It's about 4 times body weight. Weight loss is an important part of managing knee arthritis, and hips too, but especially knees. Okay, this is a North Carolina study. 50% of U.S. adults, 66% of obese adults will develop painful arthritis by age 85. I think that's just sort of reiterating something we've already said. Okay, I'd like to talk about this just real quickly too. It comes up all the time. These two words sound the same: osteoarthritis, osteoporosis. They are completely different. They have nothing to do with each other. Osteoporosis is thin bones. The density of the bone is decreased. It is more common as we get older. Osteoarthritis is arthritis. It is more common as we get older, but one does not cause the other. They're only associated because they're associated with age. You can have advanced thinning of the bones and no arthritis, and the other way around is also possible. Okay, so this is just a quick thing. Osteoporosis, what's that mean? Well, here's a bone, a micrograph of bone. These are literally calcium spicules. This is what the internal architecture of bone looks like under a microscope. That's what it should look like. This is what osteoporosis is. It just thins out. It's not as strong because this calcium, which makes up the strength of the bone, is disappearing. And there's a lot of causes for osteoporosis. We won't get into that too much right now. Okay, symptoms of osteoarthritis. Pain in the affected joints tends to be worse with prolonged use. It also often happens at night. People will tell me it hurts at night when I lay down and not doing anything, but I can't go to sleep because my knee hurts. Very common. Stiffness, especially after you've been sitting for a long time, getting up after driving to Missoula, you can't get out of the car very well. And they'll often have these grating or catching or popping sensations. Think again of a joint with no tread. No longer smooth, it's an irritated surface, and it catches and pops. How do we make the diagnosis? History, physical exam. We do some blood tests sometimes. Inflammatory arthritis, often we'll have abnormal blood tests that help us determine that. Osteoarthritis, the common wear and tear type, is normal. Your blood work is normal. X-rays are the mainstay of diagnosing arthritis. Not MRIs, not CT scans, plain X-rays typically are enough information that we know what's going on. We don't see everything on an X-ray, but an X-ray shows a boatload of arthritis. That's the problem. I don't need to get an MRI of your knee and look for cartilage tears or ligament tears, because that's not the issue. Once you get a bunch of arthritis, that becomes the primary pain generator, and we don't get a whole bunch of other studies. Now, it doesn't mean we never get MRIs when we're looking at people with arthritis. But if we're talking about advanced arthritis, we're having to think about potentially having an operation. X-rays are usually enough to determine that. What do the X-rays look like? So here we are. Here's a knee X-ray. So we showed before, we have bone, femur on this side, tibia on this side. The surface of the joint in there is that smooth, glistening surface, but it's invisible on X-ray. So when it's present, the bones should have separation between them. So that's a relatively normal knee X-ray. When that surface goes away, it's not there anymore, so the bones touch. So that's when you hear the phrase, it's bone-on-bone arthritis. That's what we're dealing with. The surface is worn away. What's left is the bone. Hip is the same way. We've got a nice gap between the ball and the socket there. That's what we'd like to see. When that wears away, the tread's gone, and that's an arthritic hip. Typically, people with this hurt in the groin, by the way. So I'll have people come into the office a lot and say, oh, my hip hurts. And they'll grab their butt. Yeah, sometimes hip arthritis can hurt the back in your butt, but typically it's up front. This is sometimes referred pain from the back. Groin pain is where the action is for hip arthritis. Shoulder, same way, nice gap between the bones, the ball in the socket of the shoulder. Again, here it is worn away. The bone is touching the bone. This spur down here, you see this, here's a normal shoulder here, there's no spur. Here's the shoulder here, here's the spur here. Taking away the spur, I'll have patients sometimes come in and they want me to whack this spur off, and somehow that's going to make things better. And that sounds appealing, and sometimes spurs in particular locations, we might have a little bit of benefit from just removing a spur, but that's not the problem. The spur is a secondary result. It's something the body does when we have arthritis. Removing this doesn't restore the surface of the joint up here, and it doesn't work most of the time. So spur removal in advanced arthritis probably has no place. Okay, what are we going to do? Sounds sort of funny, but activity helps arthritis. Study after study, I can tell you this, I can show you study after study that prove this, that when you get knee arthritis, when you get hip arthritis, we want you to try to stay active. Retreating to the couch may make you feel better temporarily, that is for this minute or that hour, but it actually makes you worse long term. We want you to stay active. We want you to ride a bike. We want you to try to walk. We want you to do water aerobics. Water aerobics have an additional advantage is that it's not very weight bearing. You can be in the water, and the water takes most of your weight away from an arthritic hip or knee, and so that can be very useful for staying active while not causing yourself increased pain. Yeah, so that's what we want to do. And whether we're treating this surgically or not surgically, we want to have you hurt less, be stronger, and do more. So how do we do this? So like everything in medicine, we start with the easy things and advance to the hard things. We're going to say surgery is the hardest thing, so it's always the last step. So what do we do for arthritis? There are various medicines available. Most medicines for run-of-the-mill osteoarthritis. Now, this isn't the rheumatoid inflammatory arthritis, because those are different. And by the way, they don't work on routine run-of-the-mill osteoarthritis. These fancy, expensive things that rheumatoid patients might be on are specific for the problem that's causing their issue. They won't work on people with routine osteoarthritis. The drugs that we use for osteoarthritis are non-steroidal anti-inflammatory drugs, NSAIDs, and you'll hear people talk about NSAIDs. Very common, very old class of drugs. There have been very few new ones released. In fact, I'll go ahead and say, I think the last one was probably around in 2000. There was a medicine called Vioxx released that is now off the market. Vioxx had some cardiac issues with it, but there are 2 anti-inflammatories, NSAIDs, available over the counter if we don't count aspirin. Aspirin is an NSAID too, but it has some additional properties. The 2 that are available over the counter are naproxen, which is Aleve, or ibuprofen, which is Motrin, or Advil. They work just as well as the prescription ones, and they're less expensive. The disadvantage of Advil or Motrin or ibuprofen is that you have to take it 4 times a day in order to get maximum benefit. Aleve you only have to take twice a day. Both of those medicines are introduced for over-the-counter use a number of years ago in about half the dosage that I would prescribe by prescription. The dose of Advil or ibuprofen, they come in 200 milligram tablets, and the bottle says 1 or 2 tablets at a time. If I'm writing a prescription for Advil, which is available still by prescription, I would write a prescription for either 600 or 800 milligrams 4 times a day. Similarly, for Aleve, which is naproxen by prescription, it's available over the counter in 220 milligram tablets. If I write a prescription for that, it's 500 twice a day. Another way of saying that is, maybe I shouldn't tell you this, you can double the dose that's on the bottle of Advil and naproxen and still be in the safe dose range for those medicines. Now,
Doesn't it like raise your blood pressure?
well, we'll get to that, yeah. So there are some issues with these anti-inflammatory medicines, all right? So, by the way, there's about 6 or 7 ones by prescription, and as I said before, they don't necessarily work any better. The prescription anti-inflammatories, there's a couple of them with some advantages, but in terms of pain relief for arthritis, they don't necessarily work better. There can be people that respond to one and not respond very well to another. So what I will typically do is start people on the less expensive over-the-counter things. If they don't work, we might try 1 or 2 of the prescription ones before we give up. So you're not necessarily immune to all of them. I think it's worth experimenting a little bit. So what's the problem with these medicines? All of them have, as their number one issue, stomach upset. They can make you irpy, they can give you stomach pain, and they can cause ulcers. Most people don't have that problem, but it does happen. Another issue with them is that they can cause kidney and liver problems, especially if you take them for long periods of time. We can monitor that with kidney and liver blood tests, and if they start to show abnormalities, we can stop those medicines. So that's something to keep in mind. And finally, the issue is that increasingly the internal medicine doctors, the family practitioners, don't like these medicines because they seem to be associated with some heart problems, heart disease. Not necessarily so much high blood pressure, but just heart attacks and strokes. Now, all that said, you think, oh my gosh, that sounds terrible. I never want to take those. All medicines have side effects. If they don't work. If they have no side effects, it means they probably don't work, all right? So all of them have side effects. These are safe medicines for the vast majority of people. I don't think we should be afraid of them. I just think we need to be aware of what side effects are and not treat them like candy. Again, I tell people in the office, there are billions of dose experience with Motrin or Aleve. Billions. That medicine has been prescribed for 25 years, millions and millions of times a year. And we're not even sure if it really has cardiac side effects, if it really is associated with heart attacks or with strokes. We think perhaps there is some association, but it's still a safe medicine. And I prescribe them, and I think if we do it correctly, it works. So medicines are the first stage. There we are. We went through all this. Aspirin is a non-steroidal, a very old one. It's available, of course, over the counter as well. Ibuprofen, naproxen, we just talked about those things. I didn't put down any of the prescription ones up here, but there are, as I said, 6 or 7 of them. What else is available? Okay, you guys have perhaps heard about this, glucosamine chondroitin. It became very popular maybe 10 years ago. It carries a number of trade names. Osteo-Biflex is what a lot of pharmacies sell it under the name of. Does it work? I don't know. There were a couple of studies in the maybe 2010, 2011 era saying, geez, this stuff seems to be better than just taking placebo. There have been other studies that say that's a bunch of hogwash. This stuff doesn't work. I have no problem with people taking it. This does have very few side effects. Again, going back to my previous statement, if it has no side effects, perhaps it's not working very well. I do have patients who swear by it, who will tell me this stuff really helps me. And here's what I tell people to do, and this applies to anyone in this room too. If you want to take a supplement like glucosamine or fish oil or any of these other things, shark cartilage, gelatin capsules, or people take for arthritis, I tell people to not change anything else. Start taking your glucosamine and chondroitin. Do that for 2 weeks. If you're convinced you feel better, stop taking it for 2 weeks. And if you're convinced it really makes a difference, start taking it again. I think that's fine. But that's how I do it. Can't change too many things at once, though, or you're not sure what might be making you better. So these are safe. Does it work? If you say so, I'm all in favor of it. What else can we do? Well, you'll read this, too, if you read some things about arthritis in lay journals or like in the AARP thing. Will often have articles on treatment of arthritis non-surgically, biofeedback, hypnosis, real yoga, acupuncture, magnets. I have no problem with these things. And again, I have some patients who really feel like they get benefit from them, and I'm all in favor of that. Yes?
Can we go back to the fish oil? What does that mean?
Yeah, well, fish oil does lower cholesterol, so it works for that. So most people, I think, take fish oil for cholesterol lowering. Does fish oil lubricate joints? I don't think so. But I think that's why people take it, is that it's purported to make joints slipperier. But it does lower cholesterol, so the internists are happy with that approach. Okay, what else can we do? Again, remember what bothers, or the reason joints hurt, the cartilage wears away, that irritates the lining of the joint, things get all inflamed. Well, we want to decrease the inflammation, which is why the non-steroidals, the NSAIDs work, but we can inject a stronger non-steroidal into the joint. Cortisone is a steroidal, as opposed to non-steroidal, anti-inflammatory agent. By the way, cortisone is related to prednisone, which is taken by mouth, but also can decrease inflammation. There's so many side effects of oral prednisone. We don't do that very often, but we do inject cortisone into joints. Now, does that change the underlying process? No. Does it make your arthritis better? No. Does it make it feel better? Yes. It especially makes it feel better relatively early on in the disease process, and it lasts for a longer time when we use it relatively early on. Once we get to that stage where I showed the x-rays before, where it was bone on bone and all those spurs and all that whiteness you saw on x-ray, that's called end-stage arthritis. And while we'll try cortisone to buy people some time, it's unlikely to work very well or last very long. Cortisone remains the tried and true thing we inject in joints. So you hear someone say, yeah, they injected my joints. Probably it's cortisone or one of the cortisone derivatives that we inject in there. Is it appropriate to give cortisone injections so you can enjoy your vacation on the beach? Yeah, I think it is. People come up a fair amount saying, geez, I'm going to Europe and I'm taking my granddaughter to Europe and we're going to be walking all over Italy and my knee's killing me. What can I do to be better 2 weeks from now? Well, cortisone. It'll help for a while. Now, another thing that's now around that you'll again read about is the so-called viscosupplementation. Synvis, these are just manufacturers of the same stuff. This stuff is actually called hyaluronic acid. I don't know how it works. It's not an anti-inflammatory. It's not really joint grease, although we sometimes talk about it as joint grease. It's felt to perhaps work by making the existing, the cells that make up the cartilage, the surface of the joint, it perhaps works by improving the nutrition of those cells that are left. But we're really not sure how viscosupplementation works. The disadvantage is that it's typically given as a series of 3 injections rather than just 1 for cortisone. They're usually a week apart. And the other disadvantage is it's very expensive. Most private insurers will not pay for this anymore without pre-authorization. You have to show that you've tried lots of other things. You have to prove to them that they got arthritis. You've got to send in these forms. Medicare still will pay for it. I've been giving this talk for a little while. I predicted 2 years ago that Medicare would stop paying for this because there's a couple studies that show this stuff doesn't work very well. They're still paying for it. And I don't need pre-authorization for Medicare. What else can we do? Well, we've talked about daily range of motion exercises, strengthening endurance exercises. We want you to stay active. Physical therapists, I think, have a role in this, but most of this stuff is stuff you do on your own at home. If we send you to physical therapy for exercise, for arthritis, it's 1 or 2 visits, because this is an ongoing process, not a short therapy intervention. There we are, same thing. Do braces work? I don't know. No, yes. I think the simplest braces, these little neoprene pull-up sleeves, that one's actually a little bit more complicated. It's got straps and hinges, but they make things you can get at Big Bear or out at Shields that just look like wetsuit material that pull up over your knee. Do they help? Yeah, maybe. They don't really change anything, but if you think it helps, I think that's terrific. How do they work? Maybe by improving balance and providing local warmth. These are fancier braces. These are semi-custom to custom braces. We'll just go over this a little bit. I've had a little bit of success with these. Arthritis over here on this side of the knee where the red thing is right there. What happens is your weight bearing ends up being concentrated over there on this side of the knee. This brace is meant to unload this side of the knee. If this side of the knee is pretty good, think of a force being applied to the knee here. Push there, so the knee sort of opens up. It opens up this side and puts weight on the good side of the knee. That's the principle of unloader braces. As an aside, I think I have a little bit of time here. As an aside, in the old days, before we had knee replacement surgery, and just every once in a while now, we would treat arthritis on this side of the knee with an operation where we break or cut the bone down here, realign it so that this moment is permanent. So we'll take the knee here and bring it out like that. Make a knock lead, and what that does is it transfers the force from the bad side of the knee over to the good side of the knee. It only works for when you have arthritis in certain places. If both sides are bad, it doesn't work. But if it's only in one side, that's called an osteotomy. We still occasionally do that, especially for young people with bad arthritis. Crutches, walkers, canes. I'm a big believer in canes. People's lives really can be a lot better. You can sometimes avoid having an operation altogether if you're willing to use it, especially in the very elderly. So when all else fails, there we are. Open the box. So top of the ladder, surgical treatment. So what about surgery? Surgery, what we're talking about here is joint replacement surgery. So I'm going to go through that a little bit. Knee replacements are not new knees. Knee replacements are new surfaces on your existing knees. We don't cut out the whole knee and put in a big old hunk of metal that replaces it. The ligaments, the things that hold the knee stable, are still there after knee replacement surgery, but the surface is now made of metal and plastic. A similar thing happens on the hip. It's hard to really put a new metal ball or a new metal cap on the existing ball of the hip, so most of the time we remove the whole ball and put on a new ball. But again, the ligaments, the thing that makes things stay stable in a joint, stay. That's joint replacements. That's what this procedure is called. We can talk about some of those things later in a bit. I think I have some pictures here that show this. All right, let me go backwards just a second. Arthroscopy is not knee replacement surgery. By the way, the word for knee replacement is arthroplasty. Arthroscopy means look inside the joint. So sometimes early on in arthritis, in special situations, with other things going on inside the joint rather than just the loss of the surface, people can benefit from doing an arthroscopy, looking inside the joint with cameras. And we have other places where we have instruments that go inside the joint, and we can make things a little better by cleaning things up. You'll hear of athletes, football players, having knee scopes in the off season to sort of clean things up. Now, it doesn't get rid of the arthritis, but we can clean up some other things and make things feel better. As the arthritis gets worse, this has no role. Arthroscopy does not help an advanced arthritic knee or hip. By the way, most arthroscopies are done in the knee. There is such a thing as hip arthroscopy, but it's not very common, and it's for very specialized things. That's what this looks like. So arthroscopy means we can debride this. So here's that picture of the joint again. It should be that smooth, glistening picture that I showed earlier. This is what early arthritis looks like. It looks like grass is growing on the surface of the joint. Now you see here, there's no yellow. Remember that one picture I showed you, the yellow down at the base? That's the bone. The bone's not exposed here. This is irritated. We have another name for this. I don't want to get too complicated. We call that chondromalacia. But the surface should look like this. But sometimes cleaning up these grass-growing areas can smooth it over and make things feel better for a while. The underlying process, unfortunately, of arthritis continues. So I would consider for arthritis, arthroscopy is a temporizing measure. Okay, I'm going to go through this real quickly just because it comes up in the office. Sometimes people will have a problem with the surface of the joint that's not truly arthritis. So we'll see, this is the end of the thigh bone right there, the pictures I've shown before. Decent looking cartilage there, decent looking there, not perfect there, but then they have this defect, a pothole. This is generally not a senior citizen problem. This is often an athletic problem. Often a direct blow has dislodged a section of cartilage. We don't want to put a knee replacement. This patient might only be 28 years old. We don't want to put a knee replacement in there, especially when the cartilage is good there. And there, we just have a problem in the center. So how can we get the body to fill that in? That's what we'd like to do. So people will come in and go, oh, I read that you can make new cartilage grow onto this knee. And we can in very specific instances where we have a pothole with good surface around it. We can sometimes get new cartilage to grow in there by drilling out the bottom of the pothole, having the bleeding effect come from that, fill that up, and that bleeding then slowly turns to scar tissue, and the scar tissue slowly turns into a new surface of the joint that works better than this. Not perfect, but better than this. And again, just for completeness, it also is a way of transferring cartilage from one part of the knee into that pothole if that first procedure doesn't work. So again, here's a knee. We walk on this part and on that part. The cartilage right there doesn't really have too much function. We have special instruments that can take a cylinder like this from a place that we don't need it and transfer it over to the place that's empty and hopefully get that to regrow. So those are for cartilage transplant techniques that you'll sometimes hear about. I mention them just because people read about this and think, oh, that's what I need for my arthritis. Can't we just put some new cartilage in there? And the answer is no. So this is what joint replacements are. Again, this is sort of a complicated one. These are what's called partial knee replacements. We had this side of the knee would have been arthritic. This side's good. We don't necessarily do the whole thing. These are still popular, although less popular than they were 7 or 8 years ago. This is what a hip replacement looks like. I think we go through that. This is a knee replacement. Think of the end of the thigh bone sitting right down in here. To do a knee replacement, I literally make 5 cuts on the end of the thigh bone. 1, 2, 3, 4, 5. The end of the bone gets removed in wafers. It's not one piece. I can't give you your knee. It's just stuff. It just looks like junk when a wafer's a bone. On the top of the tibia, we cut off the top, put this metal tray in there, metal cap on the end of the thigh bone, and this plastic disc then locks into position on this metal tray, and the bearing surface is metal, in this case cobalt chrome, on plastic. These are the companies that make these prostheses have come up with really, really well-designed systems of jigs that we hook up to your leg. There's some that actually go down the center of the bone that act as reference points. But they allow us to make very precise cuts, very reproducible cuts, so that the angle of your knee is correct, the stiffness of the knee, the tightness of the knee is correct. They've become very reproducible operations. When I was in training 30 years ago, this was done by hand. So you just open it up and go, okay, I think I'll cut it about there. About right. So we don't do it that way anymore. It's all very precise. These are examples of some of these jigs that we use to get these precise cuts. This one right here, you can see the saw blade is set up here to make that cut right down the top of the tibia there to remove just the right amount of habit. That's what they look like when they're done. Metal cap on the end of the thigh bone, metal tray on the top of the shin bone, plastic insert in between there that acts as the actual bearing surface. Hip replacements are the same idea. We need a new ball and a plastic socket. That's what we want, the metal ball on the plastic socket. We need to attach the ball to something. We're going to attach it in the hip replacement to a stem that goes down the shaft of the femur. We remove the ball itself of your hip, put this in. The purpose of this is to hold that, and the purpose of that is to hold that. So when we put it together, there's your new hip. Almost all hip replacements done in the United States now are plastic on metal bearing surfaces. In Europe, there are a subset of hips that are done that are ceramic on ceramic. So ceramics are like a toilet. They're just a really hard, smooth surface. They machine very easily. They can be made very, very smooth, so friction is less of an issue, and they're very durable. The problem with ceramics is that they can squeak. Imagine if you had a squeaking hip. They can squeak, and they can catastrophically break. Most hip replacements done in the United States are plastic on metal. I'm going to go one other place with this too. 5, 6 years ago, it became all the vogue in orthopedics to do so-called metal on metal hips. You folks may have heard of that. Metal on metal meant that the ball over here was machined to very tight tolerances to accept another metal ball that was more this size, and
The idea is that there would be very little wear because it's metal on metal. And that is true. The metal on metal didn't wear very much. The limiting factor in joint replacements is this plastic. That's what wears out. We'll get back to that in a second. Metal on metal hip replacements are essentially off the market because there are a whole bunch of problems with them. If you want to get into that, I can talk about it, but there's a whole bunch of problems with metal on metal hips. They're essentially off the market in the United States, essentially off the market in Europe. So our hip replacements today are metal on plastic, and that's the same as the knee. The bearing surface is metal on plastic. There have been some remarkable improvements in this plastic and the durability of this plastic over the last 8 years. This plastic is made of polyethylene, and companies, material scientists have figured out a way to make that more durable by a process called cross-linking. So that's important only in that if you had a hip replacement done in the 1990s, if it's still working, great, and I think hip replacements should work for 20 years, even our old hip replacements. But our new hip replacements with this new, more durable plastic should last longer than that. I'm saying should because the way we know how long one of these things lasts is to put it in 1,000 people and follow them for 20 years. And we see what the failure rate is after 20 years. Well, this hasn't been available. This new plastic isn't available for 20 years. We have studies that the companies have done. They have these tanks that they put a hip replacement in. They load it with the same force that body weight is. And they just move it day and night and day. And then every 2 months, they take it out and look to see how much wear on the plastic is sustained. In those tests, this plastic looks great. So is it going to result in a 25, a 30, a 35, a 40-year hip replacement? No. But this is a big improvement because that's the limiting factor, plastic wear. That's what that looks like in the body. Again, this goes in the shaft of the femur. The socket goes into the space that the socket is. The socket's called the acetabulum, but the bearing surface is metal on plastic. Okay, I think this is my last slide. Yeah. So what's different? What's changed? Hip replacements, knee replacements are essentially the same operation for the last 10 or 15 years. The operation itself is essentially the same. The materials have improved. Our surgical techniques have improved. We get people up and get them going faster than we used to. Our hospital stays are shortened because of that. Because we get into the hip, that's called an approach, because of the way we surgically get down to the level that we need to operate. We have improved that and strip less tissue and sort of be nicer to things than we used to be. Our recovery time is shorter, but the operation is essentially the same one that we've been doing for 15 years. I think I'll leave it at that for right now.